pulmonologist. So what I'd like to do is go over the epidemiology of pulmonary hypertension in congenital heart disease. I'm going to go over the impact that it plays on both morbidity and mortality, and I'm going to talk a little bit about diagnosis and management. The latter part I'm going to try to focus on a little bit from the standpoint of how complex it is and how important it is to involve all the various groups that are involved in treating this problem. It's a great time, I think, in congenital heart disease because we are now seeing a lot of adults with congenital heart disease, and it's exciting to look at a table like this and show you a pie chart that on the left, if you're in the 1960s, your chances of survival to adulthood were only about 15%, depending on the type of congenital heart defect you were born with, but you can see the majority now are surviving to adulthood. They're making it through that first and most difficult year, and it's amazing how well these patients are doing. Now, one of the most difficult things that I face is when I see patients in my clinic is actually going over the fact that often patients have been palliated. They have not been cured of their disorder. That comes as a very difficult fact for some of these patients. They will cry often when that's discussed with them that they haven't been cured. And the reality is that the palliations themselves can cause problems. Some of these lesions can recur, and it's very important for these patients to be regularly followed. Even simple lesions can cause problems such as pulmonary hypertension, which we're going to go over today, but arrhythmias and heart failure are also very common. Now, if you look to get a sense of what the epidemiology for these patients is, there's really two ways to look at this. You can look at large databases of pulmonary hypertension, or you can look at large databases of congenital heart disease and look at the opposite problem. So in this case, this is data from the REVEAL registry looking at pulmonary hypertension across the United States, and you can see in the patients with associated pulmonary arterial hypertension, about 20% of those patients had congenital heart disease lesions. So that means about 1/10 of patients being seen in the average pulmonary hypertension clinic have congenital heart lesions. Now, as I mentioned, the other way to do this is to look at a large congenital heart disease registry, and this is actually taken from the Dutch registry called CONCOR. And what they saw was that about 60% of patients had lesions that would not predispose them to pulmonary hypertension. About 40% did, and you can see that about 10% of their entire cohort did eventually develop pulmonary arterial hypertension. Now, it's a highly morbid condition. One of our former fellows that trained with us several years back, Boris Lowe, did a very nice study when he moved on to Montreal, where he looked at actually all congenital heart patients in the province of Quebec. We have a nice way of looking at those patients in Canada and other places. Unfortunately, we don't have that same type of registry in the United States. We're working on that, but we haven't designed that yet. So about 38,000 adults that he looked at, you can see about 2,200 of those patients had a diagnosis of pulmonary hypertension. So that meant about 1 in every 17 patients. And what he found was that the causes of morbidity here is mortality was twice as high, morbidity was 3 times as high, and hospitalization days are about 3 times as many. So having this particular diagnosis in concert with congenital heart disease really increased the morbidity and mortality. Now, this is the other way that they looked at it, which were mortality curves here, survival curves, and this is where it becomes scary. I think Kristen mentioned, the cutoff of age 60. This is worse. This is a cutoff of age 40, which makes me feel very nervous since I'm well into the 40s now. And you can see that regardless of whether you're considered younger by this group or older, you still did more poorly in terms of survival if you had pulmonary hypertension present. Now, hospitalizations are also growing in this particular patient population. You can see that over the course of about 8 or so years, you can see the hospitalizations were increasing for all types of congenital heart disease. But if you look at the right side here, where you can see pulmonary hypertension is a major component of that, as are things such as arrhythmia and pregnancy, et cetera. Now, pulmonary hypertension not only impacts all these things, but it actually makes people feel pretty poorly as well. And if you look through this is another slide from the CONCOR registry, and if you look at their pulmonary artery pressures here based on functional class, that in general, these increase, as the pulmonary pressure increases, your functional class is in general worse. So these are fairly limited patients. Another way to look at this is through exercise capacity. We had a beautiful talk this morning about exercise and what we're looking at here. And you can see that if you look at peak VO2, Eisenmenger patients, which are one of the groups we're going to talk about in a few minutes here, have probably some of the worst exercise capacity of any of the patients that we take care of. As a matter of fact, if you saw a patient who had a peak VO2 that was well under 14, that'd be somebody you'd be looking at transplantation in, and this is the average, functional capacity of some of these patients. Now, pulmonary hypertension can come from a variety of different lesions. As I mentioned, even simple lesions like the shunt lesions, ASD, VSD, PDA. And in these cases, the larger the defect, the greater the risk for developing pulmonary hypertension. There are moderate defects. These are like the sinus venosus defects, anomalous pulmonary venous drainage, primum ASDs. Some of the complex PDAs or VSDs fall into this moderate risk category. And we do occasionally treat some complex patients, those patients with transposition, some of the heterotaxy, single ventricle patients. They can also develop pulmonary vascular disease. Now, this is the major culprit. It'll make up most of what you see in the congenital realm in terms of pulmonary hypertension. Those are the atrial septal defects, the ventricular septal defects, and patent ductus arteriosus. Now, patients both repaired and unrepaired can develop pulmonary arterial hypertension. The incidence is thought to be somewhere around 2 to 10%. There's increasing dyspnea, declining exercise capacity, progressive increases in pulmonary vascular resistance. These are all hallmarks that this disorder may be present. If pulmonary hypertension develops in the context of congenital heart disease with an unrepaired lesion, about a quarter to a half of those can progress to Eisenmenger syndrome. Fortunately, we're seeing much fewer of these patients. I think we're getting much better at recognizing these folks. It's rare for somebody not to get repaired these days with one of these congenital heart lesions. And actually, one of the most important things that's occurred recently is that in infants, they now advocate checking pulse oximetry. It's a simple thing to do, but it's amazing that people weren't doing this before. But it's now considered part and parcel of the workup. So risk factors for developing, I mentioned type and size of defect. Usually the larger the defect, the more downstream it is in the circuit. So ASDs are less common than VSDs. PDAs more commonly cause pulmonary hypertension than VSDs. But VSDs are in fact the most common lesion we see associated with pulmonary hypertension. There's a magnitude of shunt flow basically that's important, the greater the amount of shunt. But remember, shunt is a moving target. I often get asked this question, what QPQS do you use? Fortunately, the guidelines have changed. We're now looking at right ventricular sizes. We're not really emphasizing. We're looking at actually the end effects of that shunt. Because remember, shunt is a moving target. As the pulmonary vascular resistance increases, your shunt may actually diminish. So that's important to recognize. Type of surgical repair, some of the corrections can actually increase the risk of developing pulmonary hypertension. And then the patient age. The older you are, the greater your risk is. Now, there's been an attempt to try to classify the patients with congenital heart disease. I don't use this particular classification, but I think it is important at least to recognize there is pulmonary hypertension that occurs after corrective surgery. As I mentioned, that is a well-known, well-described group of patients. It appears that their outcomes may not be better, they may actually be a little bit worse than the patients who have open defects. These are patients with smaller defects where we think perhaps this may be two separate problems, the fact they've got pulmonary hypertension because they've got some sort of genetic predisposition, and the congenital heart defect may have been a driver or may have been associated, but not the only problem associated there. Then there's pulmonary arterial hypertension associated with systemic to pulmonary shunts. And then finally, there's Eisenmenger syndrome, which is when the pulmonary vascular resistance gets to the point that you now start reversing the shunt in somebody with an unrepaired shunt. Now, echocardiography is often the first step taken, as it is for other types of pulmonary hypertension. We really want to assess the systolic pressure if we can in the pulmonary bed. We want to estimate the size and function of the right ventricle. We want to screen for other congenital heart defects. It's not unusual. For instance, we'll see patients with septal defects who also have a cleft mitral valve, or we'll see other abnormalities. So it's important to recognize those. And we want to identify as much as possible other causes for pulmonary hypertension, including left-sided disease. If you look in the BACH group, the Boston group, actually, there's some unpublished data suggesting that as many as 85% of their pulmonary hypertension evaluations result in non-PH diagnoses, left-sided disease, et cetera. Now, this can be pulmonary venous, as I mentioned, or pulmonary arterial. So just seeing an elevated RVSP does not tell you. So this is where I strongly advocate for the importance of heart catheterization. Depending on the lesion, you can have dysfunction of either of the ventricles. And it gets a little complicated when we start talking about things like transpositions, where often we talk in terms of a systemic ventricle and a pulmonic ventricle. So not always is the RV the venous ventricle. Sometimes we see the right ventricle as the systemic ventricle. That's a very different physiology. But heart catheterization really is where this is the final diagnostic test to really allow you to recognize what you're dealing with and how to treat it. I also like to do a pulmonary vasodilator challenge. I don't often exercise people in the cath lab, and part of that reason is just we don't have the proper equipment. I think it's really important, as was mentioned by Dr. Lewis this morning, to make sure that you're properly assessing what the cardiac output is. I don't think you can just exercise a patient, see what their pulmonary pressure does, and feel comfortable that you understand their physiology. You want to unmask potentially pulmonary venous contribution to pulmonary hypertension. This is one of the things I use the vasodilator challenge for. And finally, there's been a lot of discussion about reversal of disease and the idea that maybe you can take things back a certain number of steps and take a patient who has Eisenmenger physiology and perhaps make them correctable. I will tell you my own experience with this is I've yet to see a patient that I felt comfortable occluding a defect where they actually had Eisenmenger physiology at one point. We've treated them, we've improved their symptoms, but rarely do I feel that we can do something in somebody with an uncorrected shunt to actually correct that problem. In any case, if the video was playing, you'd see that this is a sort of in between a subcostal and an apical four-chamber view. There is a VSD that's present, and there was bidirectional flow across the VSD, so there's flow in both directions. This is somebody that we got to too late who's developed Eisenmenger syndrome related to a ventricular septal defect. Now, people have repeatedly used this little diagram here telling us what happens in patients with systemic to pulmonary shunts. But you can see that what ends up happening eventually is you end up getting increased blood flow and pressure. There's pulmonary vascular remodeling, and people make it pretty clear. Then you get resistance, then the flow reverses, and you get Eisenmenger syndrome. I would submit to you that this still is the proverbial, in this case came out as a white box, but it's the proverbial black box. Many of us don't understand what goes from this step over to this step, and I think this is a really active hotbed of research in terms of trying to figure out why certain patients develop this problem and other patients don't. Now, there is now a growing body of literature looking at the cardiac biomarkers that have been looked at, a number of different biomarkers in these patients, markers of inflammation, markers of right ventricular subpulmonic ventricle strain, potential genetic mediators as well. Eisenmenger syndrome, as I mentioned, was really what we try to avoid. This is the classic description was by Wood back in 1958. In this case, as I mentioned, what happens is the pulmonary vascular resistance is now at systemic levels, and now your shunt reverses. So instead of getting flow from the left to the right side, so instead of going from systemic to pulmonary bed, now you're getting shunt from the pulmonary bed out to the systemic bed, so you're getting deoxygenated blood in the systemic circuit, and you get cyanosis. Now, there are multiple complications that can result in these patients. They get erythrocytosis, they get proteinuria and reduced GFR, they have increased uric acid. It's a well-known fact these patients are at risk for problems such as renal failure. I think people recognize that that's not such a good thing to give these patients contrast dye in the cath lab, but I'm amazed how often patients will show up in the emergency room and they routinely get a CT scan to rule out pulmonary emboli. Please be aware that they are at considerable risk for developing renal failure. Some of the other things to think about, arrhythmias. Sometimes it doesn't have to be a ventricular arrhythmia. These guys are at risk for ventricular arrhythmias, but even an atrial arrhythmia, atrial fibrillation with a rapid ventricular rate can be potentially deadly. They can syncopize related to that. Anesthetic agents, any simple surgical procedure can turn into a nightmare if the anesthesiologist is not familiar with their particular problems. Phlebotomy. I get so many patients sent to me that are being routinely phlebotomized. Not such a smart idea. It turns out that actually looking for iron deficiency is something you want to look for. A lot of these patients have a revved up system. Their bone marrows are making a lot of red blood cells related to their hypoxia, and a lot of them are actually low on iron. If you replete their iron, you actually help them. You help their oxygen carrying capacity. Actually, you reduce their risk for sludging. If you actually remove their red blood cells, you actually make them iron deficient and increase their risk for sludging. particularly if you don't give them adequate hydration back. So the worst thing you can possibly do is remove blood without giving back saline. And even worse than that is just removing, or as bad as that is just removing blood. So you really want to make sure that that phlebotomy is truly indicated. We only do phlebotomy if the patient has symptoms related to sludging, and most of those are neurologic symptoms. If a patient presents with something that looks like a stroke due to sludging, that's the patient that needs to be phlebotomized. So this is a telling, I think, series of papers, and this every decade up to right around the year 2000, there's been a publication of congenital heart disease, Eisenmenger syndrome outcomes. And what you can see here is a very flat survival curve. Unfortunately, this didn't show up, but 40 is right about here, 50 is right about here. So it's somewhere between 40 and 50 is the average length of survival. I'm fortunate to say I think that we're doing much better with that in the last couple of decades. So I think it'll be very exciting to see what's happened in the last 15 years, because I can tell you up till then we had this idea that wasn't much that we could do for Eisenmenger syndrome, but now we believe we can. Now, I do want to emphasize the importance of catheterization. So this is a patient that was sent to me for Eisenmenger syndrome referral. He was a 62-year-old gentleman and a history of a hole in his heart. He said that it closed on his own. He had been feeling well, but was experiencing then progressive dyspnea and fatigue. Over the last year, he saw his primary physician. He had an echocardiogram. The echocardiogram was red, and this is directly coming from the report, likely early Eisenmenger syndrome. So his physical examination showed a slightly elevated blood pressure. He had no cyanosis or clubbing. Without cyanosis or clubbing, it's not Eisenmenger syndrome. So we knew something else was going on here. He had a loud pansystolic murmur. You should not hear loud murmurs in these patients. Occasionally you'll hear the TR. It can be kind of a low-pitched rumbling noise. But this guy had a very loud sound that kind of argues that there had to be a fairly sizable amount of turbulence from one ventricle to the other. And so his blood work was pretty unremarkable here, but he did have a pretty profoundly impacted 6-minute walk distance, and he desaturated 85%. This is his echocardiogram. We've got our moving pictures back. Thank you. And so this guy actually, this is a parasternal long axis view. He has a lot of turbulence here near the left ventricular outflow tract, but it's actually not in the LVOT. This is a small ventricular septal defect that's there. But more telling was the fact that this was kind of a lowish velocity. And so the other thing that we did is we actually looked at his pulmonary outflow, which had been missed. And so he had a fairly considerable pulmonary outflow obstruction. So this guy actually had about a 90 millimeter gradient across his right ventricular outflow tract. And so what we figured out is he likely had a VSD that had partially closed. And when it closed, he developed RV outflow obstruction based on its location. And so this guy actually, this is his right ventriculogram. And this is an interesting picture. The pulmonic valve is up here. This is part of his tricuspid valve being sucked up into the RVOT. So this is kind of the equivalent of hypertrophic cardiomyopathy with systolic anterior motion, but it's actually the right ventricle. So we figured this out. We actually sent him to surgery for his pulmonary outflow repair. He had a VSD closed at that point. His RVH actually subsequently improved, and now he's WHO function 1, class 1. So this was actually was a reversible Eisenmenger, but it wasn't Eisenmenger in the first place. So it's important to try to figure out the physiology. So what options do we have? We now have a variety of things to choose from. We have percutaneous therapies, surgical therapies, pharmacological therapies, and then we have the ability to do some hybrid therapy, some things we can do in the operating room where we do certain things catheter-wise together with the surgeon. This is one of the reasons why I told you earlier there's been a little bit of hesitancy about this whole idea of closing defects. These are ASD data and VSD data. You can see that actually for Eisenmenger syndrome, this comes from the European data. You can see that the worst outcome of these two lesions was with Eisenmenger syndrome. But what was scary was up here. The open lesions with pulmonary hypertension did slightly better than the closed lesions. So if you actually developed pulmonary hypertension from a closed defect, actually your outcomes were a little bit worse. This kind of brings up this idea that in certain patients, that ability to shunt blood from one side to the other may have some potential benefits. So who should we do? Who should we repair? Obviously, what we're trying to identify is the side on the green here, obviously, if somebody's got pulmonary hypertension, but we think they've actually just got mainly an elevated pressure, they maybe have a high output and a fairly normal resistance. In those patients, surgical or catheter interventions are possible. Obviously, this is what we don't want, which are people with permanently remodeled vascular bed. As Dr. Farver showed us this morning, we really don't want to take somebody with those really fixed advanced lesions and send them to a catheter or surgical repair, because in that case, we may actually decompensate their right ventricle, their subpulmonic ventricle, and cause more problems. Now, there have been now papers looking at which type of, of numbers we want to look for. So a baseline pulmonary vascular resistance index less than 6 Wood units really is where we want to ideally, or PVR less to SVR ratio less than 3 in the absence of vasoreactivity. Again, I like to look for vasoreactivity testing as well. If they're vasoreactive, I think that makes me a little bit more comfortable sending the patient either to surgery or to a catheter intervention. Now, some of the other things that we can do, this is actually a patient with a patent ductus arteriosus. It's a little bit hard to see, but this is a ascending aortogram. One thing we can do is, this is a ductus. This is actually a balloon across the patent duct. We can actually balloon occlude the defect and actually remeasure the hemodynamics. Now, that requires several sets of catheters in place, several access lines. So we actually go up and measure the pulmonary pressures with the balloon occlusion. We measure the systemic pressures. What we ideally want to see is we want to see the pulmonary pressures drop. We want to see the systemic pressures stay the same. And if that's the case, then we can feel very comfortable closing that defect. Now, there are a series of therapeutic approaches to the patient with pulmonary hypertension and congenital heart disease. I'm not going to go over all of these other than to point out that there really are some discrepancies. So if you look at actually a chart that's designed for patients that have pulmonary hypertension, you may be steered in the wrong direction. For instance, oral anticoagulation, we have very little data that does very much for our congenital heart patients. As a matter of fact, a lot of these patients are at risk for things like pulmonary hemorrhage, and so you want to be careful when you're anticoagulating them. You may actually do something worse for them. Now, obviously, if they're going to have indwelling lines because they're getting IV therapies, that's a little bit of a different picture. Long-term oxygen, another one, right? We feel comfortable putting on a lot of these patients on oxygen. If you have a shunt lesion, oxygen does very little for you, right? Because your problem is that you're bypassing the lungs. You're not getting blood out to the lungs. Doesn't really matter how much you hyperoxygenate the blood to the lungs. Now, this happens all the time. Patients get admitted with Eisenmengers. I come in the morning, they're on 100% non-rebreather. Everybody's freaking out. Their SAT's 85%. I walk into the room and I take the mask off and I show the nurse that the SAT's still 85%. So that's your definition, right, of a right to left shunt. Now, I will bring a caveat to that because there's a couple of papers now very nicely showing these patients also have pulmonary disease as well. So a lot of them will have restrictive lung disease. So there is some benefit to oxygen in these patients, but hyperoxygenation probably not so. Now, this is a very complex curve. Again, ideally, we want to get these patients into the hands of physicians that have expertise in this. There's a lot of supportive measures that we recommend. Things like putting air filters on their IVs if they've got a shunt is very important. Again, avoiding phlebotomy. This is something I have a discussion every time I see a new patient like this, discussing, make sure your local physicians are not drawing blood. There's no reason to do that unless you're symptomatic. Again, further down here, again, we want to do catheterization. I do acute vasoreactivity testing. If they are reactive, basically, these are patients potentially, we don't do the reactivity to look at whether or not they can be treated with calcium channel blockers, but simply to assess at what stage of disease they are and whether they potentially will be responsive to therapy. Now, in terms of therapy, we've known for several decades now that Eisenmenger syndrome does have the same type of biomarkers that patients with other group 1 pulmonary hypertension will have. This is looking at endothelin levels. And so the first study in congenital heart patients alone, this is in Eisenmenger patients, was the BREATHE-5 study done in the early 2000s. There was initial fears that the saturations would worsen in these patients, so they actually randomized these folks in 2-to-1 randomization fashion to either bosentan or placebo. They showed very nicely that the oxygen saturations did not worsen, and in fact, their 6-minute walk distances improved, and their pulmonary vascular resistance improved as well. There have since been other studies looking at other cohorts of patients with congenital heart disease with other agents. This was actually looking at ambrisentan, showing very similar data in terms of functional improvement. There's also been data looking at the use of PDE5 inhibitors in these patients as well. The experience in general until recently is has been fairly limited, but there have now been several studies, including this study from India, demonstrating that these patients had a reduction in their resistances. Their shunts kind of went all over the place, but in general, it's very interesting because sometimes you'll take a patient who's got a small shunt because they've got high resistance, and then you'll put them on a vasodilator and bring them back, and their shunt is actually higher. They've got more pulmonary blood flow, and it kind of makes you wonder, whether you're doing the right thing. But in general, these patients do feel better. They walk further. It makes us feel a little bit better. This is probably the most exciting slide I'll show you all day, and this is from the Royal Brompton group, looking at patients with no advanced therapy versus advanced oral therapy, and look at the difference in survival. So this is mortality, cumulative mortality over time. This is actually looking at corrections for all the various differences, and the patients that were treated with advanced oral therapies actually did significantly better before and after adjustment for the various differences. So I think this is very exciting that we may not only be changing how well people feel, how far they can walk, but we're actually potentially impacting on their survival as well. Now, there has been some data looking at prostanoid use. It does make us a little bit uneasy when we put patients on IV therapy. Now, we looked at this data here ourselves. We found that, in fact, that there were no embolic events, there were no systemic infections in the patients that were treated, but we could not demonstrate that there was any mortality difference between these two groups of patients. In fact, we saw slightly that things headed in the other direction. So it may be a marker that maybe we're getting a little too aggressive in these patients, but I think that remains to be seen. In conclusion, I think it's important to look for pulmonary hypertension, even if these patients have been repaired, do a thorough workup, make sure these patients get cath before you just throw them on treatment. Work with the specialty centers for both PH and congenital heart disease. Look for iron deficiency. Don't routinely phlebotomize, and adapt your approach. Don't just simply follow the algorithm because it can get you into trouble if that algorithm's not adapted to congenital heart disease. I thank you for your attention.